I would like to introduce Assunta De Francesco. Assunta is the Acting Senior Health Promotion Officer at the East Metropolitan Community and Population Health Services, which is part of the East Metropolitan Health Service. And I serve on the board of the East Metropolitan Health Service. The centre has over 20 years' experience in health promotion. She has worked with a range of settings, including local government, health services and community across the SNAP area: smoking, nutrition, alcohol and physical activity. In her presentation titled East Metropolitan Health Service Tobacco Brief Intervention, the ABC Pilot Project, Armidale Hospital, the centre will present a case study of how the Alfred House ABCD program or project was adapted to Armidale Hospital. With pleasure, I welcome Assunta. Thank you.
Yeah, great. All right, hello everyone. Let me know if you can't hear me. So thanks for the Cancer Council for inviting me to present today about the ABCD project that we piloted over a 6-month period at Armidale Hospital, and we did that under the Director of Medicine, Dr. Suresh's guidance and support, and unfortunately he couldn't be here today. And with this particular project, we're now also piloting it at Bentley Health Service and at RPH. But I'd like to state and acknowledge right from the outset that the ABCD project is not our own project, but rather one that we adapted from Alfred House. And on that note, we certainly couldn't have implemented the project without their support, and in particular Emma Dean's assistance. She and the team were very patient, answering all of our questions and often ringing and sending lots of emails and sharing resources, for which we're really appreciative. And so it's very exciting to finally meet you today, Emma. So as Kingsley mentioned, today, my presentation is actually in 2 parts. The first part will be describing the background and rationale and what we did, and then the second part of the presentation will look at some of the evaluation and some of the results that we found. But before we do that, just very quickly about who we are and what we do. So we're part of East Metro Health Service, which covers 3,648 square kilometres, and there are 13 local governments in our areas. And in 2015, we had over 650,000 people in our area, or just over 25% of the state's population. And in terms of the work that we do, we work very closely with government, community and non-government agencies to reduce lifestyle-related diseases by working across some SNAP areas, which has already been mentioned: smoking, nutrition, alcohol, physical activity, and of course this project is an example of a tobacco smoking-related project. And in terms of statistics, if we look at the stats and look at our area, 13.6% of adults are current smokers in our area, which is higher than the state of 12.2%. Now moving on to our project. So our project specifically, the overall aim is to increase the number of people who access the Armidale Hospital's canning ward to be smoke-free during their hospital stay. And I mentioned the canning ward because that's where we piloted the project. In terms of the rationale, the project was piloted in response to patients not complying with the WA Health System smoke-free policy, and the evidence which shows that pharmacological treatment can actually help to improve patient comfort and compliance to smoke-free policies. And I've also highlighted the last point that shows that, taken a step further, there is great potential to improve long-term smoking cessation amongst patients who smoke by systematically documenting their smoking status, providing brief counselling and pharmacotherapy to smokers, and offering post-hospital discharge support. And essentially that's what our project is about, and I'll talk about that and break it up further. So the ABCD, what does it actually stand for? The A component is about asking all patients about their smoking status and determining their level of nicotine dependence, because patients' nicotine dependence can vary and not one size fits all. And so as part of the project, what we're promoting is the phagostrom test to help actually determine patients' level of nicotine dependence and the recommended NRT therapy. So basically it's a two-question tool that asks how soon after waking do you smoke your first cigarette and how many cigarettes a day do you smoke. And the first question is actually the more important one. A lot of, in the past, people have only asked how many cigarettes do people smoke, but but it's actually that you need to look at the two questions combined to actually then determine people's nicotine dependency. And it's really important then to make sure that the level of NRT is tailored to a person's level of nicotine dependency levels. So basically this is really important because in speaking with Alfred Health, underdosing is ineffective and essentially a waste of resourcing. And it's in this component that physicians play an important role because they're often the ones who complete patients' initial assessments, who can actually ask them about their smoking status. Moving on to the brief intervention component. So that's about providing brief advice to stop smoking to all patients who smoke, and it's giving patients a clear message not to smoke after leaving hospital. And what we really want to promote here is about offering NRT to patients to help them deal with withdrawals while they're in a smoke-free environment. And also offering them the NRT regardless of whether or not they actually do want to quit. And certainly what we found with our results is that even if patients, so if you offer the NRT, there's actually a really good uptake, and that's something that we found. And this is where we really engaged the nursing staff to come into the role as well, and I'll talk more a bit about that later, especially in terms of offering referrals to relevant supports. So what we had was some quick packs, and we asked the nurses to hand those out to patients, and those quick packs had lots of information that they could read, regardless, again, whether or not they were interested in giving up smoking, because we felt that it was a bit of information that they could read and it might actually just kind of get them thinking about it. And then finally, the CD component, that is the communication at discharge. And again, that's where we engage the physicians, and that's asking the physicians to include the smoking status and the action that they took on the patient's discharge summary, so that the doctors in the GP surgeries know what's going on with their patients, and then they can continue that conversation when the patients leave the hospital. And I suppose this is about acknowledging that patients' journeys do not just begin and end in hospital. And one of the things I'd like to say about this is that a lot of the people that we've been working with, the nursing staff and the physicians at Armidale Hospital, are already doing a lot of this. But what we really, and a lot of this may not necessarily be new to them, but what we really like about this ABCD model is that it's basically just strengthens the good work that they're already doing by providing a simple memory aid, and it provides a systematic approach to supporting patients who smoke. So I'm just going to describe now some of the strategies that we actually implemented for the project. So we piloted the project in the Canning ward in line with the capacity building model, which some of you may be aware of. And basically this model considers the multiple processes and strategies that all happen behind the scenes and that need to happen to facilitate a project. So if we start off with leadership, so our health promotion manager, so we were able to do the project because she spoke to Armidale Hospital's chief executive, who then permitted us to pilot the project. And our manager was able to use the issues around compliance to the WA smoke-free policy and promoting positive health outcomes such as reducing the revolving door of smokers going into hospital as a way to influence change and to basically to get support on board. So then with the permission granted, we were then able to meet with the Director of Clinical Services and the Director of Medicine of the Canning ward at Armidale Hospital to actually start the planning process. Then in partnership, well, it's not a project that we can do on our own, and certainly it represents a great partnership between the hospital and our unit. And given the great experience in supporting smoke-free hospitals and workplaces, we also connected with the Cancer Council, and I'll also talk more about their role shortly. Organisational development, that refers to all the internal organisational systems and procedures and structures that need to be in place to actually support the project to occur. So, for example, this involved discussions about whose role would it be to do each of the ABCD components. And so, for example, it was more appropriate to engage and, to work with the nurses to do some of that brief intervention component, because they were more likely to have more frequent interactions with patients, and they could help raise the issue if they were doing a blood test or taking a temperature, for example, and able to kind of bring it into their work in more like an incidental, opportunistic way. And then as a part of the evaluation, we needed to complete the appropriate paperwork so that we could undertake the patient file audit, and I'll talk more about that actual process that happened later as well. Resource allocation, I mentioned about the quick pack, so certainly we looked at what resources were needed to give to the nurses and physicians to deliver the project, and then workforce development. Certainly, you can't expect people to implement a project if they don't have all the relevant information, and this is where we ended up delivering a number of different sessions, and I'll talk more about that as well. But I've just got a picture up there of Dr. Hayden McRobbie, and that was one of the videos that we used, again, that we used from Alfred House, and we used that particular video when we delivered the physician presentation, and he just talks about the importance of brief intervention, and yeah, so it was a very good resource that we were able to use. So thank you, Alfred House, again. So in terms of what we did, so we delivered one session to physicians, and which approximately 20 participated, and we delivered 6 to nurses in partnership with the Armidale Health Service Pharmacy and the Cancer Council. And basically these sessions were used to inform clinical staff about the project, providing background, what types of NRT was available for patients, and that was really important. So not all clinical staff were actually aware of actually what was available. And also then this is where we were able to work with Doris to come in from the Cancer Council to look at looking at the strategies and tips on how to raise the issue in a non-judgmental way, and in a way that that nurses and would also feel comfortable as well. But yeah, so basically how to raise the issue with patients. And those sessions vary between 30 minutes to approximately 1 hour. And I'd just like to state at this point, we delivered the information session with physicians after the first patient file audit was conducted. So in other words, the training for the physicians was conducted between audits 1 and 2. And this is important to note when we look at some of the results, and might also account for some of the results that we found. And you can see that we handed out over 250 quick packs, as well as 50 lanyards. So I've just got, I don't know if you'll be able to see this, but this was the example of the lanyard that we put into a lanyard that the nurses and physicians could then wear around their necks and refer to when they were actually looking to determine patients' nicotine dependence. So now this brings me to the second part of my presentation, and looking at the evaluation component. So the patient file audit was, the patient files, were audited against the ABCD model to identify any changes in managing the patients who smoke, and certainly I'll talk more about this shortly, and that's why I've highlighted that. But I'll also just very quickly highlight some of the other evaluation components. So we had a very simple one-page evaluation form that we asked nurses to complete at the end of their information sessions, and certainly the feedback there was very positive, saying that the sessions were very informative, and they felt confident to be able to implement what we were asking them to do. And I'll talk more about that later as well. We've also conducted an observational audit, an idea that we again took from Alfred. We've been very good at borrowing ideas from Alfred. And what we will do is we hope to repeat the audits and then hope over time to see reductions in the number of patients who smoke as a result of being supported to quit and or to be comfortable while in a smoke-free environment. And certainly at Alfred they saw significant reductions in that, but I won't say much more about that in case Emma talks about it. So in terms of the methodology, so 4 patient file audits were conducted last year. As I said, it was a 6-month project. So that was at 2 monthly intervals from June, August, October and December. And we were looking at the first 2 weeks of each month, and our focus was on the physician's activities. So that's what we were auditing, the doctor's activities. And the first audit formed the baseline and was conducted before the project officially began. But going back to those internal processes and systems that I talked to before we could actually implement the project, we needed to complete Alfred Hospital's GECO form, which actually gave us permission to access files or patient files because it's very sensitive, and basically the GECO form is a quality improvement related document, and we needed to show why the audit was required and how it actually linked to the National Safety and Quality Health Service Standards. And what we were able to demonstrate through that is that it linked to the clinical governance standard. In addition, I liaised with the Business Intelligence Unit to identify the relevant patient file unit medical record numbers using particular codes, and this was a whole new system for us, and certainly it's been a learning process for our unit. And for those of you who aren't, who are not familiar, because I didn't know who the Business Intelligence Unit was before this, but they provide data analytics, data engineering, data science and business intelligence information. So they were really very helpful and helped us streamline the process. And of course we liaised with the Armidale Medical Records Patient Information Department. So once we had the numbers or the codes, we were able to then go to them and ask them to retrieve the records for the audits. Unfortunately, the coding process doesn't allow us to identify which patients were not asked about their status, not asked about their smoking status. So what this meant was, and we acknowledge that this was a limitation, but due to the limited capacity, we weren't able to audit every single patient file. It would have required doing like going through 860 files. So basically, when we're looking at the results, basically what we were able to do was just audit those that were smokers and to see if indeed they were current smokers and had actually had that, question completed. As part of the process, then the data gathered from the patient records was recorded on a data audit sheet, which was then entered and analysed on Excel. So just looking now at our sample, so we had a total of 119 patient records were identified as smokers during the auditing period. Unfortunately, however, our final sample was only 74, and this was because there were only 74 files that were available on the day for actual auditing. So files may not have been available because the patient had been readmitted into hospital and you couldn't remove their file from the actual ward. The record was waiting for an outstanding discharge summary, or the record was being used for another audit or meeting. So they were some of the factors that were basically out of our control. In terms of the results, so I'll just go through each component. So we can see there that the ask component was done very well, and in fact it was the most well achieved of all the components. and you can see that 3 of the 4 audits achieved 100% identification ratings. But this isn't surprising, really, given that the medical assessment form that the physicians are asked to complete when a patient is first admitted actually includes a question on smoking status. So that's really helpful. If you've got the question there, it's good to know then that it makes it a whole lot easier. Okay, 2 minutes, thank you. Brief intervention, good, I'm nearly done. Brief intervention, this is where we observed a modest improvement, but you'll see that the greatest improvement in BI was observed from audit 1 to audit 2. And this is what we think is that maybe the information sessions that were scheduled may have had an influence in prompting people or reminding physicians to ask the question and offer the NRT. And what you don't see here is our results, that we found that while the overall percentage of patients offered NRT was low, except in audit 2, it was encouraging to note that the majority of patients who were offered NRT actually accepted it. So we really want to make sure that we continue to promote this. And then, just mindful of the time, quickly looking at the CD, this was the most where we saw the greatest amount of change, which was really exciting. So we could see from from baseline, it went from 8% to 31%. But certainly there's some more work that we can continue to do in this area. Limitations, small sample size, limited resources and capacity. We couldn't basically look at every single file, and the limitations, we were only looking at the physician's activities and not nursing staff. So now the recommendations, just really moving on, there were some really positive outcomes as well as lessons learnt which influenced the recommendations. We have the support of the Canning Ward to continue the project for another 12 months, so that's a really great outcome. We want to continue the sessions with both nurses and the physicians because we can make sure it's a prompt and a reminder to promote the NRT and keep writing the information on the CD. And one of the things that we're currently doing at the moment is a survey with nurses to identify whether or not they said they were going to be able to, they felt confident in doing the BI, but actually find out, what were some of the challenges, were they actually able to do what we were asking them to do, and also to expand the project to other departments. We're working now with mental health, and we also want to work with the GP surgeries out in the community as well. Here are some references. Sorry, I've gone really fast there. And as I mentioned, there are lots of people that have been involved in this project, so I'd really like to acknowledge it's a partnership approach, and so thank you very much.
One of my children was once given a T-shirt that said, you can always tell a Victorian, but you can't tell them much. Now, some of my very best friends are Victorians, and it is a great pleasure to welcome Emma Dean to this seminar. She's been the leading, Alfred Health's leading cessation or smoking cessation expert, and Alfred is leading the country in this area. So she's a pivotal person in this context. She has a background in pharmacy and has a wonderful population or reputation nationally for her work with this sort of field. Alfred Health is the leading in developing and supporting comprehensive approach to smoking cessation. She's held positions in population health and health promotion as coordinator, and has been a lead pharmacist in SmokeFree in the Alfred Hospital. She had 15 years experience in the Victorian health system and leadership positions in population health, and was mentioned in clinical pharmacy and research. She has certainly been the driving force in developing a multidisciplinary system for change to the entire clinical management of nicotine dependency at Alfred Health, and more recently across Victoria and extending across nationally. She's a member of the Royal Australasian College of General Practice expert advisory group for smoking cessation, and she's frequently involved in teaching and training of healthcare professionals, delivering the most up-to-date evidence-based knowledge. And in this particular field, it is with great pleasure, Emma, that we invite you to the podium, and thank you very much.
Awesome. Thanks so much for the introduction. I just wanted to declare that I have no conflicts of interest, so not paid by tobacco or the pharmaceutical industry. So I just wanted to tell you a little bit about Alfred House and our journey so far in smoke-free. It hasn't always been so great, but we are a really big hospital in metropolitan Melbourne. We see about 106,000 patients every year for emergency presentations, and we have about 110,000 inpatient encounters a year. We do a lot of elective surgery. We're a statewide service for transplant, trauma, HIV. But what's also really interesting about us as a health service, we're a really big employer, and that was a really important consideration for us when we were looking at what we were doing in the area of smoke-free environments. So this is what Alfred House looked like, top left-hand corner, back in 2008. So you can actually see that we had a designated smoking area. This is our main courtyard. So it was in a really prominent place, and I'm really pleased to show you what it looks like now. But we went smoke-free in 2008, and we had a CEO at the time who was all about doing things quickly. So she gave us 3 months to go from having designated smoking areas to having none. So it wasn't a whole lot of turnaround. So when we looked at kind of the objectives for this particular transition to smoke-free, it was around not only demonstrating public leadership, but also to reduce that exposure to passive smoke. So what did we do to achieve this? We put in a policy, we put up some signage, and we communicated it. So not surprising when we came to see what actually happened as a result. Well, there was high awareness because designated smoking areas were being pulled down all over the place, but we still had a whole lot of issues with compliance. We had patients and staff smoking on site, and nothing different was happening clinically. So we weren't doing anything to support our patients or our staff who smoked at this particular point in time. So things kind of continued for, the next few years. And it was in 2011, and some of you may or may not remember this hitting the media, but we actually had an involuntary patient in our mental health unit take Alfred House to VCAT, citing an infringement of her human right to not be able to smoke while she was an involuntary patient. This particular, point was really pivotal for Alfred House. We had a different CEO at this time, the CEO we have now, and at one point we were looking at actually getting quotes to reintroduce designated smoking areas. But we had Kirsten Corbin, who I'm sure you probably all well know, who was in the lead role at this time, and she really challenged our executive and our board to actually go through with this VCAT challenge. And what was really interesting that came out of it, that there was no right to smoke, but there was certainly no right for a health service to put people in a smoke-free environment and not support their addiction, and to manage that addiction and to make their stay as comfortable as possible. So not surprising when we came to a new approach a few months later, our objectives were much broader. We obviously still wanted to have a safe, comfortable environment for our patients, our visitors, our contractors, our employees. We still wanted to have a role in public leadership, but now we were broadening our approach. We wanted to facilitate smoking cessation amongst our patients, amongst our workforce, and also recognise that there were going to be some patients where smoking cessation or quitting smoking was just not on their radar, but we had to manage their temporary abstinence while they were in our health service. And we also wanted to denormalise smoking, and I know this might sound a little bit strange in that I put here prevent uptake, but there was certainly a small number of patients who came to Alfred House as a non-smoker and left as a smoker prior to this time, particularly within our mental health services, where they were not using other substances and were moving to cigarettes as a way of managing, that particularly challenging time. And we also recognise that one of the biggest drivers of people relapsing back to smoking is the visual, is the smell, and we really wanted to minimise, for those who have quit, to stay quit. So when we came to what we were doing now, much broader. Comms was still really important. How were we communicating this? Were we using posters? Were we using the intranet, the internet? What were we using? So we had a really broad comms strategy. We had a really big emphasis on what we called the clinical management of nicotine dependency. And we framed it like that because we wanted to engage clinicians. We wanted them to understand that this wasn't just a public health issue, that smoking was a clinical issue. So it was important when we were framing it that it sounded that way. And that was underpinned by a really robust clinical guideline with fantastic support from all our heads of medical units within Alfred House. And also education was pivotal to what we were doing. So what happened this time round? Well, we still had high awareness. We interestingly had increased compliance, even though we were focusing on it less. So we had significant reductions in perimeter-based smoking, and we were also achieving best practice clinical management, which is what all health services strive for. So I'm just going to show, hopefully, just a little video. Sorry, it didn't embed properly.
As a leading Australian healthcare provider, Alfred House is committed to creating a totally smoke-free environment for all.
We're really proud to be Victoria's first major metro health service to introduce a totally smoke-free
not going to work.
environment.
That's okay. Doesn't look like it's going to work. I'm not sure why. Let me try and play it. I'll just leave it, I think. But that was basically our Executive Director of Nursing Services talking about our journey in smoke-free. So we were really lucky that we had that really strong executive and leadership support. So when we looked at why this particular round and why this particular approach to smoke-free worked, one of the biggest enablers, no doubt, was our organisational leadership, our CEO, our executive and our Primary Care and Population Health Board subcommittee. And it was really around us looking at this as a problem that needs solution, and that we communicated publicly and actively so that the patients that were coming to us expected this. And if they weren't, they were actually challenging us, why haven't you actually spoken to me about smoking? And our CEO is very much known for not so much about why we should do things, but how can we not? How can we not, as a leading health service, put smoking higher up on the agenda, considering it is the largest preventable cause of death and disease in Australia? With our clinical leadership, we had really strong engagement from our clinicians as well. We committed to best practice. We allocated resources, whether it be people as well as pharmaceutical. And we made sure we had that support for patients and our support for staff. Again, a really robust approach to education, so actually embedding it in systems already in place. So for our nursing staff, it was the use of electronic learning. For our medical staff, it was integrating it within, basic physician training or routine training for HMOs or residents, and also the use of grand rounds to be able to reach, the audience of the health service. And we had a continuous improvement focus, so we knew this wasn't going to be a short-term journey, and 8 years later we're still working on this. But we needed to find ways to measure performance, which is not always easy. So it required us to think outside the box a little bit, and we wanted to innovate, almost with a safe-to-fail type of mentality and trial new approaches. So when it came to our clinical leadership, for us, we wanted to have clinical leadership that was clearly defined. So back in 2011, before we had this approach, we talked to clinicians and everyone thought it was everyone else's responsibility to have these conversations. So the nurses thought the medical staff were doing it, the medical staff thought the social workers were doing it, so no one was doing it. So for us, we needed to have a clearly defined clinical leadership, and I'll talk about our approach in a little bit. And we wanted to integrate it. It needed to be easy, sustainable, and it had to be done without a major resource injection. It had to be systematic, every person, every time, especially in those areas of greatest challenge. So within our mental health, within our HIV service and so forth. We needed to measure our performance, normalise this practice, and we also recognised that for this particular part of clinical practice, we had to emotionally compel our health professionals to do this. So we used a lot of our patient stories to be able to do this. So it was that little bit of evidence, but really using that emotional side to compel our health professionals to think, hey, I've got to do something in this space. So when we came to our clinical management process, for us, we went with a pharmacy-led model. Now, particularly in Victoria, there's lots of different models within pharmacy departments, but at the Alfred, we have a really, really strong pharmacy department where our pharmacists are actually attached to units. So they round with our orthopaedic team, they round with our haematology team. So we went with a discipline that sees every patient soon after admission, throughout their admission and at the point of discharge. And for us it made sense that it would be the pharmacist, considering one of the biggest things you can do to support a patient either quitting or when you're looking at managing temporary abstinence is the use of medication. So we allowed our pharmacists to initiate NRT and prescribe NRT. So we made sure that we had the processes in place to support that. We also had nurse-initiated NRT as well, again, to support pharmacy prescription and obviously medical prescription. And we had an agreed treatment algorithm. So we actually had a standardised kind of way of starting patients on what we think was the best evidence-based nicotine replacement therapy at the time. We also wanted to make sure that we had all forms available, so every single formulation currently available on the Australian market on every single ward impress throughout our entire health service, so that we had rapid access to it, recognising that for a lot of people when they come into hospital, they're probably already going to be in withdrawal. So to wait for the doctor to prescribe, wait for it to be dispensed from pharmacy, just wasn't the approach that we wanted. We also made sure that we were looking at what were we doing for patients following discharge, what services did we have, particularly for those really complex clients to support long-term cessation. Stop before the op, which is probably one of my most proudest achievements, and I'll talk a little bit about that in a second, but supported by our amazing head of anaesthesia, Professor Paul Miles, and the surgical team to allow us to really start looking at the opportunities that we have as a health service to influence smoking cessation before people rock up for the day of surgery. We also looked at the opportunities in creating an outpatient clinic to provide face-to-face support for those looking at making a long-term quit attempt, and also our Good News for Smokers campaign, which was our support program for staff. So what have we been able to achieve? So in our inpatient setting, we've been able to show that the provision of brief intervention has been increased from 14% back in 2011 to more than 95%. And we've stayed there for the last, 4 or 5 years. We had, I suppose, challenges similar to Assunta has talked about, that we were able to use coding data to particularly look at those clients who were smokers. But we're really, really lucky that we have a really great research team, and we also get a whole lot of students which were actually able to help us look at, about 1,000 medical records that we would retrospectively audit every quarter to be able to provide those performance results. We were able to also look at, okay, we're providing brief intervention, is that leading to smoking cessation? And we were able to show that our inpatients were 4 times more likely to quit than those who received no support. So about 15% of people were quitting or were smoke-free on the day of surgery, on the day of discharge and at the 6-month mark. So Stop Before the Op was an initiative together with our anaesthetic and surgical teams delivered through our pre-admission service. So basically these patients were provided a brief intervention based on the ABCD model, so the CD in this particular case being communicating back to the primary care providers prior to surgery. And they were provided with evidence-based nicotine replacement therapy at the time of the pre-admission clinic appointment. So they were handed it over then and there. They were provided with referral to smoking cessation services for behavioural support, whether it be Quitline or our face-to-face service. And we also used a carbon monoxide monitor within this setting to biochemically verify our results. And we repeated that test on the day that they came in for surgery. So we were able to show that patients were 4 times more likely to actually make a quit attempt prior to surgery. So about 53% of people who smoked made a quit attempt prior to surgery when we delivered this brief intervention, compared to 11% in our control, and these results are statistically significant. Patients were twice as likely to be smoke-free. So about 23% of people who smoked who were delivered this brief intervention at the time of their pre-admission appointment were smoke-free on the day of surgery, compared to about 8% in our control group. So really, really powerful results. We were integrating this particular initiative within the interactions that were already taking place, and we were really able to get some really great results. We're looking at the next phase of this now and looking at whether or not, by these patients actually quitting, can we show improvements in wound healing, decreased post-op complications, day in the ICU, days on the ventilator and so forth. So we're looking at some further outcomes for this particular initiative. We also have a smoke-free outpatient service. This is Cam. He's one of our smoking cessation specialists. And this particular service is for patients who are particularly complex, where we feel that they're going to need frequent face-to-face support and are not going to be suitable for services such as telephone counselling. So again, these patients are provided with best practice pharmacotherapy, and they're seen generally weekly or fortnightly for anywhere up to kind of 6 to 12 months. A lot of these clients have other substance abuse conditions, mental health, at risk of social isolation and so forth. And then the other component of the kind of clients that meet the eligibility criteria for this service are patients who may need transplantation down the track, may need to qualify for home oxygen and so forth. But we get some really great 6-month quit rates, about 42%. And again, these are biochemically verified, which is fantastic. This was something that we did a couple of years now, and in retrospect, I almost wish we had done it sooner, and it was our Good News for Smokers campaign. So this was recognising that as a leading health service, caring about the health and wellbeing of our staff, that we wanted to do something to support our staff who smoke to quit. So we had smoking rates of about 4.5% among our staff, and we actually brought our staff together in a focus group and said to them, hey, we want to support you to quit smoking. If we were going to do it, what would you want? What would you want it to look like? So the campaign was actually informed by our staff. And they said to us, not a lot of things that surprised us, but they wanted funded pharmacotherapy. They wanted the opportunity to attend the smoke-free outpatient clinic like patients. They wanted the opportunity for the smoking cessation specialists to actually go to their departments if they wanted group-based support, so particularly looking at areas where we know that there is high smoking prevalence. So for us, it was our IT department, particular areas of nursing and so forth. So we wanted to run a whole lot of group consultations. And they also wanted the opportunity for emails and text-based support as well if they felt that face-to-face wasn't appropriate for them. And so what actually happened? So again, we biochemically verified these results. At the time of producing this lovely infographic, our quit rates were at 50%, but our most recent rates are 62%. So again, it just shows the power, I suppose, that we know exists within social influences and how strong they are in helping with smoking, but we were able to turn this around for our workforce and actually use those social influences to be just as powerful in quitting. It's been a really, really great initiative. As Sandra kind of mentioned earlier, that perimeter-based smoking was something we cared about as an organisation. We're a big metro health service, we're on a big main road, we often have TV crews out the front because a lot of trauma patients get sent to us, so there's a lot of media coverage. And so often there were people smoking in the background, and it just looked absolutely awful. So for us as a health service, we cared about perimeter-based smoking. So it made sense that when we looked at what we were doing in this space, that one of the measures that we wanted to be able to demonstrate was a reduction in perimeter-based smoking. So we would have typically in 2011 had maybe two 250 patients smoking out the front of the hospital within an 8-hour period. So this is a really fun job where we actually go and walk around the perimeter and count the number of patients, staff, visitors, contractors smoking. So it's an observational survey. But what was really interesting for us, and I don't think any of us realised how significant it would be, was actually at the point, so May 2012, when we started to support our patients to quit, we had an 85% reduction in patients smoking around the perimeter. So for us, that was a massive win. Not only does it reduce exposure to environmental tobacco smoke, but it was really showing us that what we were doing was resonating with the patients. They expected to be asked about smoking. They were taking up the offer of support, and it really just fed into the rest of the work that we were doing in this space. So we've always had this continuous improvement type of focus, and we made sure that we really had a definition of success. And for us, it needed to be beyond compliance, and it needed to be beyond the evidence of problems, which in a lot of cases will still be there, that there'll still be issues. You won't have 100% compliance, but it doesn't mean that the policy is a failure or is inappropriate. So for us, we needed to make sure that definition of success was really broad. It was around support for patients. It was around support for our workforce. It was around our smoking around the perimeter. So we had a whole lot of different, I suppose, ways that we can monitor and evaluate what we were doing. Consistency was a really big focus for us. And when we meant that, we meant between staff on the same unit or the same ward, and also between departments, recognising that for patients, quite often their inpatient journey will take them from the emergency department to one particular ward, perhaps to another ward, perhaps to intensive care, or perhaps to mental health, and then back to the general medical ward. So we needed to really have a consistent approach, because we do know that making an exception, which we do time to time, and we still do now, which is often done from thinking that we're doing the right thing and managing that patient at that point in the best way that we think we can, but that inconsistency can become a cause of aggression. So we really wanted to have a consistent approach across the service. We also wanted to have a focus around inequalities. So we know that there's inequalities in smoking. The last thing that we wanted was to have inequalities in quitting. So we needed to make sure that we're investing as much, if not more, into those areas such as mental health where there's those inequalities in smoking. We wanted to have a clinical leadership focus. So previously it always kind of been considered an OH&S issue. And we just wanted to influence clinical practice with a little bit of evidence, but plenty of emotion. And our Start the Conversation campaign, which we developed with the Victorian Government, was really instrumental in doing that. Now, I did want to touch on smoking and clinical aggression because it's a really hot topic in Victoria since the unfortunate death of the cardiothoracic surgeon at Eastern Health at Box Hill Hospital. And I suppose I wanted to touch on a little bit of the evidence in the literature around this, and then some research that we're actually in the middle of at Alfred House at the moment. So certainly still in Victoria we have legislation, smoke-free legislation, where people can't smoke within 4 metres of the main entrance. But there still is a perception among some health services that smoke-free environments will increase aggression and violence. And this perception remains despite the growing body of literature that actually shows the opposite when smoke-free policies are implemented well and they're comprehensive. We know again from the literature that clinically managing nicotine dependence is so important. It is a key determinant of the success of a smoke-free policy. And we know that acute nicotine withdrawal has been shown to increase aggressive behaviour. And when you think about the symptoms of withdrawal being things like irritability, agitation and so forth, it's easy to see why. So one of the other super fun things that we're in the middle of at the moment, it's quite funny, we always come up with these ideas and then we realise how difficult they are to actually do. We thought, let's retrospectively audit every episode of Code Grave in Victoria. That's an episode of clinical aggression that we had at Alfred House. So for us, it was 1,310 episodes of clinical aggression, and that's just at the Alfred campus. And this is data from 2015, and that just shows you how long this has taken. We had a full-time research assistant doing this data analysis, just the data retrieval for about 7 or 8 months. And what we really wanted to do from this was to try and understand if there were determinants of aggression. And this particular research piece is broad. It looks at delirium, it looks at poorly managed pain, alcohol withdrawal, but our particular focus was also looking at the relationship with smoking and withdrawal, and to consider, were there things that we could be doing more in this space. So what was interesting for us was that 51% of patients involved in an incident of clinical aggression at Alfred House smoke. So that's grossly overrepresented. So our smoking rate among our inpatient population is about 17 or 18%. So these results are significantly higher. And when we looked at episodes of clinical aggression in smokers, and these were just patients who had a high dependence, so at, I suppose, most risk of experiencing withdrawal if not managed well, it was only 81 patients, but they actually had 180 episodes of clinical aggression. So they were having more than one episode. What was pleasing, I suppose, in a way, is that NRT was being recommended in 94% of these patients, but it wasn't being used. It was only being used in about 52% of cases. And when we looked for clinical signs of withdrawal, they were prevalent within about 81% of cases. So we're trying to do a further kind of deep dive into this data. This is very early stages now, and I'm meeting with a whole research team from Monash Uni next week. But we're really trying to understand what's going wrong. We're identifying these patients, we're assessing them, we're prescribing, but why are they not getting it? Are they refusing it? Are we withholding it? And is that not clinically appropriate? Is it the perception that nicotine replacement therapy is for smoking cessation and not for managing withdrawal? Do we need to do some further education with our patients and our clients and our consumers? But really early stages of this study, and we hope to get some really great, I suppose, learnings from this to be able to share with health services across the state. So I think realistically, when we're thinking about as a health service, and I'm going to focus here on patients, we need to recognise that for patients, a lot of them may choose to abstain temporarily with the vision of returning to smoking on discharge. And there'll be those proportion that'll take the opportunity to quit completely. And there'll probably be those proportion who'll continue to smoke, hopefully off-site, but some of them probably on-site. But the best way of managing them is to offer support immediately on admission. And that initial conversation might be around coping while they're stressed or they're overwhelmed, and then transition to supporting cessation later in their journey or later in their time in hospital. And I think it's really important for us that for many patients, it's inevitable that they'll probably experience a period of enforced abstinence. So it's important for us to recognise that as a smoke-free hospital or a smoke-free health service, we've probably got two focuses. One around clinically managing nicotine dependency and supporting temporary abstinence, and also supporting long-term cessation. I've kind of highlighted a bit in here in red, and I think this is probably, if you take nothing else home from today, I think this is, what I'd love to get across, is that when you look at withdrawal, patients, it's pretty predictable that withdrawal is going to happen unless we manage it. Okay, we manage alcohol withdrawal well, we manage drug withdrawal well, but for smoking, we just don't tend to do it and don't tend to look at it with the same lens. So although we're a smoke-free health service, patients should never be forced to experience withdrawal. Withdrawal is predictable, it's preventable, and it's treatable. And the best way of doing it, again from the literature and certainly from our experience, is the combination of nicotine replacement therapy and behavioural support. It needs to be provided for the duration of admission, and it needs to be done rapidly on admission to hospital, recognising that a lot of these clients are going to be in withdrawal by the time they end up in the bed. Okay, just to kind of finish off, I wanted to talk a little bit about kind of best practice for smoking cessation and kind of, I suppose, get people to really start recognising that smoking is really complex. And quite often when I started a lot of the education at Alfred House back in 2011, 2012, the perception among clinicians was people who smoke, they could quit if they really wanted to. they're really annoying us, they're off the ward smoking, they're not here for their physio review, they're not here for their medical review. But people who smoke aren't weak, nor are they simply making a bad lifestyle choice. The reason why they smoke is complex, and it's made up of what we call nicotine dependence, and then the behavioural and the psychological connections that are built up over many, many years of smoking. Asunta's already gone through a lot of this, but again, we needed to have a really clear vision among our health service that nicotine dependence needed to be seen as a medical condition, where people who smoke need to be supported to abstain or to quit smoking, and they needed to be re-engaged and assisted through repeat quit attempts. And we needed to have a really strong model where our health professionals were doing this, and this was the status ROM that Asunta's talked about earlier. So again, super easy. We had to make sure that this was easy to achieve. We were able to integrate this into what we were doing, and it wasn't going to become really burdensome with time and so forth. I suppose I also just wanted to touch on one of the biggest misconceptions that patients and clinicians have around smoking. And it's the perception that smoking helps to relieve stress, helps to relieve anxiety, and it comes into play quite a lot in the mental health sector, because you quite often hear clinicians saying, oh, they've got too much on their plate, they can't possibly think about quitting. So thinking about a cigarette for a second, nicotine rapidly gets to the brain within about 30 seconds. Okay, so it binds to acetylcholine receptors in the VTA area of the brain. Because this process happens so rapidly, when it binds to these receptors, there is a small increase in dopamine, being one of the feel-good chemicals of the brain. So for the person who smokes, they feel an element of kind of positive reinforcement, that what they're doing is giving them a reward, so they want to continue to smoke. But what we know is the biggest driver of why people continue to smoke is because nicotine doesn't have a long half-life, which means it doesn't hang around in the body for very long. So it can't bind to those receptors for very long. And so the dopamine that is produced doesn't hang around for very long. And what happens when all of a sudden we don't have that feel-good chemical around? Well, we start to go into withdrawal. We start to feel irritable, anxious, changes in mood, changes in concentration, changes in appetite. So it's what we call the negative reinforcement of smoking. So the perception from the patient that I smoke and I feel a sense of stress relief, my mood improves, my concentration improves, is really just happening because the nicotine is reversing that withdrawal. So when we look a couple of weeks down the track, particularly in clients with mental health conditions, they report vast improvements in their mood, in their levels of anxiety. So it's, I suppose, a misconception that's out there that certainly clinicians as well as patients kind of cling on to say, why we shouldn't be talking to these people about smoking. They've got so much happening, it's not the right time. But in a lot of these clients, they're already experiencing the inequalities in smoking, more of the burden of chronic disease, more of the burden of financial hardship. So by us saying, well, I can't possibly help that, we're widening those inequalities even further. And we actually had a client, I remember, who was in our Gen Med ward. It was a 4-bed ward, and 3 of the 4 patients in the room smoked. And there was an older lady, exacerbation of COPD, so we talked to her about smoking, made sense, clinically appropriate. We had a gentleman who had an STEMI in his 40s. He was also spoken to about smoking. But the 32-year-old who'd had an overdose, who was homeless, with a history of mental health in the other bed, no one spoke to him about it. He actually piped up one day and said, what about me? Why aren't you talking to me about smoking? And it really challenged the clinicians then and there to think, well, I thought that, it was going to be too hard. And he said, well, why is that your choice to make? And that was really, I suppose, a pivotal moment for those particular clinicians within our general medicine ward to start thinking, let's just go on and offer support to everyone, regardless of who they are and why they might be here. So nicotine withdrawal is pretty uncomfortable. So you can imagine if you're a patient, you're in a smoke-free environment, you might be hooked up to telemetry, or you might have 2 broken legs so you can't get out the front of the hospital. You're going to be feeling pretty awful. Things like dizziness, insomnia, restlessness, difficulty concentrating. So if we're not supporting them, they're going to feel pretty awful. And it's really important that we recognise that nicotine withdrawal is significant. And the duration and severity of the symptoms are really variable amongst individuals. So again, we just don't know how it's going to, or how a certain person is going to actually feel that withdrawal. But we do know that the symptoms are particularly bad in the first day or two. So if you think about your clinical practice, and you think about the first day or two of a person's admission to hospital, a lot of the time that's when a lot's happening with that patient. They might be having a whole lot of tests. Generally their health is at its worst. So for us kind of saying, oh, we'll wait until day 3, day 4 when he's feeling a little bit better to talk about smoking, he's actually going to have already been through the worst part of the withdrawal. And when we look long-term at how long these withdrawal symptoms hang around for, it's anywhere between 2 to 4 weeks. And the use of things like nicotine replacement therapy make these symptoms less significant, so make that patient a little bit more comfortable. I think it's important that we also recognise that the dependency or the addiction is only a component of why people smoke. People will also smoke because of how they feel, their moods, their emotions, and the behaviours that are built up over many years. So it's really important that patients are provided with behavioural support to particularly, I suppose, tackle these aspects of smoking as well. So that's where services like Quitline, QuitText, QuitCoach, certain apps, self-help materials, face-to-face smoking cessation services come into play to help clients work on these other aspects of their smoking. So hopefully we've kind of got the picture that, you know, it's really hard for patients, and as health professionals and as health services we should be doing something in this space. What can we actually do? What works? Well, we know that brief intervention works. So a model like as Swim has described, which is the ABCD model. So the Victorian model, it works well because it kind of makes sense, and it also really recognises that integral point at the patient being discharged back to primary care, that CD component. And we know as health services we generally do that component quite badly when it comes to everything. But really important to, again, get that primary care provider on board to provide that ongoing support. So how effective is brief intervention? Well, we know that it prompts people to quit, and it roughly doubles long-term abstinence rates. And when you think that this conversation might only take you a minute or two, potentially for about 60 minutes of your time, an hour of your time, one of those clients will go on to being smoke-free. So the number needed to treat for brief intervention is 1 in 33. And we know still from some data over in the UK that health professional advice is still the greatest external trigger for prompting a quit attempt. People value what we say. Obviously, there's good and bad ways to have these conversations, but they do care about what we say. So we need to actually just get on and do it. We also know that stage of change doesn't matter. So for those of you that have worked in smoking cessation for a little while, there was the 5 A's model. And the second A of that brief intervention model was to assess, I suppose, stage of change or willingness to quit. And this is a really lovely study. It's quite old now, but it's from Scandinavia. It was 1,600 patients. And basically they asked them, are you ready to quit smoking or are you not ready to quit smoking? And not surprisingly, 11% said, hey, yep, I'm ready to quit. But 89% said, no, not interested. But in this particular study, they went on to provide best practice support to both of those groups. And only 52% of those that were ready to quit took up the offer of support. Interesting, considering they said that they were ready. But what I think is even more interesting is that 24%, a quarter of those that said, I am not interested in quitting smoking, said, okay, I'll take up that offer. And when you look at short-term abstinence rates at 17 weeks, actually 37% of those who said, I'm not ready to quit, but took up the offer of support were smoke-free. So if you think about your clinical practice and your experience, and I'm sure it's probably not a whole lot different to mine, if I actually ask people, are you ready to quit smoking, I'd probably find something similar to this. But if I don't actually offer support to those who said, I'm not ready to quit, how many patients am I missing out here? And population-wise, most of our patients are actually going to be in the not ready to quit group. So just get on and provide support to everyone, regardless of where they are. And when you think about yourself and when you might want to make some changes in your life, particularly I think about, exercise, your motivation changes, even throughout a day, even within an hour. So because someone mightn't necessarily be right ready at this point, in an hour or so when something else has changed, they may be. So stage of change changes rapidly. So it's really important that we just get on and provide that best practice support. This is some data, again, from the UK, and it's based on GPs, but I think it illustrates a lovely point. So we've got on the vertical axis the percentage of people who tried to quit smoking, and across the bottom various different experiences with their GP. So the first column is where patients didn't see their GP. And we see about 35% of people who'll make a quit attempt within a particular period. What's interesting is that the second bar is patients that saw their GP, but their GP didn't say anything to them about smoking. And there's actually less patients that make a quit attempt in that group. If you think about it, and you ask patients why, well, if it was an issue, my doctor would have brought it up with me, so it mustn't be a problem. Then we've got the column where the GP advised them to quit, but didn't offer support. We've only got a tiny increase in the patients that made a quit attempt. And again, you ask them, oh, well, I know I shouldn't smoke, I just don't know how to quit. I've tried 8 times before, I don't know what to do. But look what happens when you actually offer support. Okay, quit rates, percentage of patients trying to make a quit attempt of around 60%. And here's similar results, but these are provided as an odds ratio. So we've got, and I love showing this to GPs, to actually say to them, how often do we do a kind of tick box exercise? Do you smoke? Yes. Do you drink? Yes. Do you do? And if we don't actually say anything about it, that patient is likely to continue that behaviour. So not advising has significant risks. So again, thinking about within the clinical practice you work in, if you're going to ask these things, there needs to be follow-up. Advice to quit, advice to manage, and obviously support. So how do we have these conversations? And often I have particularly medical staff say to me, oh, I couldn't possibly talk to someone about their smoking. And I think, oh gosh, you would have some of the most awful conversations with patients that I could imagine. You would tell them that they've got, terminal illness, or that they're dying, or that they've got to have some, significant surgery. And they'll say, well, what do you want me to say? Do you want me to say, do you want help? And I'll say, well, you could say that, but perhaps making that offer of help or support needs to be emotionally salient. So quite often I'll say to patients, one of my other patients who was a lot like you really struggled, but do you know what? I got them onto this fantastic program. We provided them with nicotine replacement therapy, and you know what? I saw them last week and they're smoke-free. So you've got to kind of tell a little bit of a story. You need to explain the options, and you need to help people access that help and support. So what does best practice look like? Well, we know that it's an intervention where you use medicine plus that behavioural support. And we know this works in a variety of settings and a variety of populations. So again, as clinicians, if we're looking at provision of support, of course we want it to be in line with best practice. So we need to make sure that we're offering our clients both those things. And it's great to see that the model that's been implemented into the Canning ward has used those quit supports as well for that behavioural component as well as the medication. I like to show this list because it's really small, and I think it's important for us to remember that when it comes to providing medication for stopping smoking, the list ain't big. So if I was to put up a list of medicines for blood pressure or a list of medicines for depression, it would actually be quite big. The list is tiny. That's important because quite often if people have had multiple quit attempts, they'll have used a lot of these medicines before, but they may not have combined it with behavioural support. They may have used them incorrectly, and they're going to be reluctant to probably want to give them another go. So if we're using them and we're recommending them, we need to do it correctly. So there's a whole lot of words on this page, but I think it's important that we understand, I suppose, the limitations of nicotine replacement therapy as a medicine. First and foremost, I like to describe to consumers and patients that it's a little bit like cold and flu tablets. It takes the edge off, it makes you feel better, it makes you more comfortable, and you can get on with your day. If they expect it to work like a cigarette or give them the same feelings as a cigarette, they're going to be bitterly disappointed. So in the simplest terms, it reduces motivation to smoke and reduces the severity of withdrawal symptoms. We have 6 formulations available in Australia. So we have patches, which are long-acting and slow onset, and we have intermittent products. So I kind of like people to think of these as your as-required type of medicines. And you've got things like the gum, the lozenge, the mini lozenge, the mouth spray and the inhalator. And these are by no means a miracle cure. It increases quit rates by about 50 to 70%. So if you think unassisted quitting, so just me waking up today and thinking I'm going to quit smoking, is about 3 to 5%. Brief intervention is going to put another couple of % on that. If you add nicotine replacement therapy, it's another few % on that. Okay, so we're just nudging that patient a little bit closer to successful smoking cessation. The safety profile, and this is often one that both consumers and clinicians struggle with, and I think the most reassuring thing that I can tell people is that our TGA, our Therapeutic Goods Administration in Australia, who would be one of the most rigid and strict regulatory bodies probably in the world, have made these products unscheduled. So you can buy them in a supermarket, you can buy them from a petrol station, you can buy them from the pharmacy. So they are safe. We know that they have minimum addictive potential, and that's got to do with the delivery of nicotine from these products being vastly different to how nicotine is delivered from a cigarette. And we know that there's long-term in the data, there's no serious side effects. When they happen, they're usually minor, and they're usually related to the formulation. So, for example, lozenge causing mouth discomfort or so forth. And they do not produce what we call dramatic surges in blood levels. So for us, you know, when we think about anything, particularly pain's a good example. If someone had chronic pain, imagine giving them endo 3, 4, 5 times a day with no long-term opiate. Okay, we're getting high troughs, high peak levels of the opiate, then it's plummeting down, high levels down. Okay, so again, we need to think when we're using nicotine replacement therapy that we're wanting to produce a relatively constant amount of nicotine to make that patient more comfortable and prevent those peaks and those troughs. We need to use it for long enough, 8 weeks, gold standard, minimum, plus that behavioural support. And there really are few contraindications for use. So again, the data is really, really robust for the evidence for safety and efficacy of nicotine replacement therapy. Just in the interest of time, I'll probably finish on the slide after this, but this is something I use particularly within emergency department training within Alfred House and certainly within other health services. And I think it illustrates really nicely about what NRT does. So the pink line is a cigarette. So you can see pretty quickly, within about 10 minutes, you get a nice peak level of nicotine. Kind of makes sense. When we look at something like the patch, which is the grey line, it's pretty much doing nothing in the first 60 minutes. Kind of makes sense as well. Imagine a patient having acute pain and giving them a fentanyl patch or a buprenorphine patch. We just wouldn't do it. But it's quite commonplace, certainly within health services in Victoria. Oh, the patient has a patch, they'll be fine. But the patch is not doing a whole lot, and it won't actually reach the steady state until about 6 to 8 hours. So again, thinking about what you're using within your clinical environments is going to impact on how effective it is. And something like the spray, you're getting a nice level of nicotine again, and you're getting it quite quickly, but it's nowhere near a cigarette. And the gum, the inhalator and the lozenge, well, it's a good half an hour before it's actually reached its peak effect. And again, it's nowhere like a cigarette. So this adds weight to the idea around combination therapy, which is what I'm going to finish on here, which is well referenced in the literature and certainly best practice internationally and certainly in Victorian health services. And it's the combination of a patch plus a spray together. So the patch is providing that steady protection. So it's kind of, I say to people, it's a bit like your Seretide or your Symbicort. A lot of the patients I see obviously have COPD, so they understand the analogy of a preventer and a reliever. So I say to them, think of your patch like your Seretide. You use it every day. Hopefully you don't have a whole lot of cravings, but if you do, it's okay, because I've got one of these other products that's going to give you that quicker and more flexible relief. And then I always say to them, look, it doesn't quite work like a cigarette, it takes quite a bit longer. So let's work together and work out what your triggers are for your smoking, and then you can take that product in anticipation of that trigger, so that they've got nice nicotine levels before they're actually well and truly in withdrawal. I will just, sorry, I know I said that I finished on the last one, but I'm going to finish on this one. And I think, Sunta's already kind of summed up some of these things, but we've had lots of learnings over the last few years, but certainly the biggest one within health services and within clinician knowledge is that there's misconception around how to use these products. And generally, people don't get a dose that's adequate for them. So it's not going to adequately manage their withdrawal, and it's not going to support long-term cessation. It is so common to underdose on NRT. Overdosing is incredibly rare. And one of the other big things is we used to say to patients, no nicotine replacement therapy prior to surgery. But now we actually know that there's really good evidence to support that it can be used even when patients are fasting, as the intermittent products, with the exception of gum, do get absorbed through the buccal mucosa or the lining of the mouth. So again, patients can use these right up until they go into surgery. That is, I think, it from me. I've got a couple of other slides, but I will provide the presentations to Lorena, and then you can make them available however else. So, people are smoking, who smoke are expecting you to talk to them about smoking, know how to offer support, address their concerns. Having the conversation doesn't take long, and it can make a big difference. And best practice is the use of medicine and that behavioural support together. My details are here. We do a whole lot of work in prevention generally, so if you're working with a broader portfolio than tobacco, whether it might be around overweight and obesity or alcohol, feel free to email us at prevention@alfred.org.au. We've got some other things that we're happy to share. Otherwise, my email address is there. I'm more than happy to help with anything. That's it from me.
I'd like to ask for questions, firstly from those on video conferencing. Any questions you'd like to address to either Assunta or Emma after those addresses?
So the question was around resourcing for our SmokeFree outpatient service, and it's true that it is a really big commitment from our organisation. Our approach to SmokeFree is really broad, so it encompasses, population health as well as clinical areas and as well as our pharmacy team. So we were able to get in-kind contributions from all of those areas, almost run it as a little bit of a pilot, and we were lucky to get a grant as well. And basically we showed, great success from the implementation of that service, robust data and having those quit rates biochemically verified, and then basically just put a business case forward to our executive, and that's been operationalised now. So I think, a lot of the time doing something for 3 or 6 months, if you can get a little bit of money from lots of different departments together collaborating to be able to show some outcomes. And then, that patient voice as well, which we always use. We always get a patient story as part of what we're doing. It's very, very hard for the organisation to say no. So the other way, initiatives have happened, Stop Before the Op was the same. So some money from our anaesthetics team, some money from our pharmacy department and our population health team. And interestingly, that initiative costs us for one of our pre-admission clinics about $12,000 a year. So it's not perhaps as much as you would think it actually would. And I think that's important as well, because a lot of the time with these initiatives, if you try and calculate how much it might cost you and you work out, the patients, how much they smoke, how long they'll be in hospital for, what they might use, the results can come out really high. So sometimes, just stripping it right back, getting a little bit of money and running it, getting great data, and then putting that business case forward. Yep. So with that particular piece of research, we hope to be able to remove nicotine as an independent predictor, or nicotine withdrawal as an independent predictor for clinical aggression. And that's certainly what other health services internationally have found. There's a heap of data, particularly within mental health and forensic settings in the UK, which is, I think, the one published in The Lancet last year had a 38% reduction in staff towards staff and, patient towards, not staff towards staff, that wouldn't be good, would it? Patient towards staff and patient towards patient violence. But again, this is all underpinned by a comprehensive smoke-free policy. So where you have a tobacco treatment pathway, a smoking cessation pathway, you have the education, you have the resources, you have the access to pharmacotherapy. So again, I think that's incredibly important to remember.
Of relevance to that question, the population in prisons and cessation programs in prisons is a big issue, because their rates of consumption are huge.
Huge, yep.
Sometimes up to 85%, I think, across the board, probably at least 50%. They are there because they don't want to be there.
Yes.
The state puts them there for very good reasons, usually, not always, but mostly very good reasons. What's your advice there?
So obviously we have smoke-free prisons in Victoria. You're probably all aware of, the riot that we had a few years ago. Again, when you look at, I suppose, lots of initiatives, it's easy to see where there's room for improvement. And I think a lot of the time we don't tick all the boxes around, education, appropriate support to manage those people while they're in those services. So again, I think a lot of these clients, particularly within prison settings, are likely going to experience social and financial disadvantage once they're released from prison. So, providing them, best practice support while they're there is certainly, something that I feel really strongly that we should be doing. And there's probably, just like lots of other settings, room for huge improvement in the way that we do that. So Thomas Embling Hospital, which is a forensic mental health service in Melbourne, went smoke-free. They had a legal challenge similar to us, but their approach to smoke-free has been just so fantastic. They have utilised their occupational therapists to do sensory modulation with clients around managing, all those other behavioural components of their smoking. So I think there's some really good examples where it's been done well. And it's been both, looking at all those drivers of why people smoke, not just the addictive component, and providing that comprehensive support.
Any other questions to Emma or to Assunta? Certainly the business case must be there.
Yes.
Such a powerful
it is.
Health promotion, compared to the cost of the ramifications of smoking.
That's right.
But we need to get the figures and promote the figures and, from my perspective, as being on the board of East Metro, we need to see that the data and use it.
That's right. And I think, in prevention, it can be really difficult with the monitoring and the evaluation side and getting the data, because a lot of what we'd love to show we're not going to see for decades down the track. So I think one of the biggest things that I've learned in my kind of 8-year tobacco journey within Alfred House is that you've really got to think about the audience that you're talking to and talk how they want to hear. So if I'm talking to the surgeons, it's about wound healing. It's about, decreasing post-op complications. If it's the anaesthetist, it's the same thing. If it's our board executive, it's around, what best practice looks like. We don't want to be seen as an organisation that isn't promoting best practice. It's around the reputation of the health service, the perimeter-based smoking. So you've got to make sure you have the data there to support what you do. But I think the more that you can integrate it within your health service, if you're looking to get a small amount of funding together, it can be easier getting small bits from lots of places than one particular one, showing some amazing outcomes, making that compelling case, including that consumer voice, to be able to operationalise it. And also look for opportunities for grants as well. I think, there's a lot out there, and it can be, just a way that you can get something on the agenda to influence those that you need to influence.
Any other questions from here? Thanks.
So that was Yep, so that was the January of 2012, and then the reduction was May 2012. So it's a quarter, 3 times a year observational survey. Yep. Again, that drop was it was probably the lowest one we've had, and it's kind of blipped up and down since then, but there was so much awareness of what was happening. The education was fresh in everyone's mind. But I think, it's similar to kind of the experience that you've had with the ABCD and your performance. It does change as time goes on, so you've got to keep the education on the radar. So I think looking for options for sustainable education, whether you're incorporating it in things that are already happening within the health service is really important to keep it up there on the agenda. And I think what we learn from this is going to be very transferable to other modifiable risk factors for chronic disease. So we're looking at, we've just introduced a brief intervention for overweight and obesity as well. So I think what we're learning from tobacco, we're going to be able to look at applying for other risk factors, that are going to have a really significant impact on people's health and wellbeing.
On that one, the Live Lighter program was developed here, which is obviously a first-rate program.
Yes.
Going across nationally. You got a question?
So the question was around enforcing smoke-free. So we have, I suppose, a different way that it's done at Alfred House to a lot of other health services in Victoria, in that we have an external security provider. So they are contracted to provide security services for Alfred House. So we built managing smoking into their contract. And what's quite interesting is a lot of our security team smoke, and when we've actually started to support them to quit as part of our Good News for Smokers campaign, those conversations that they're having with visitors, with patients that are non-compliant, become so much more powerful, because they no longer feel as though they're being a hypocrite, that they're trying to tell them to stop smoking when they smoke themselves. So we've built that in, and a whole lot of training and work has been done with our security team. And again, the security team are great at having conversations. That's what they do. They de-escalate episodes where patients are getting aggressive. So for us, it made sense that we were able to, again, rally the support from them. And again, it just shows that, I suppose, our approach to smoke-free is broad. We've got our clinicians, we've got, the role for our security team, and having that really broad approach has kept it on everyone's agenda. Yeah.
Just a question there, thanks.
I haven't had any data to show that, but I think you raise a really important point about the opportunity to actually communicate this before people are on the doorstep of the hospital. So for us, and again, I'm singling mental health out, but it's because we have such a high proportion of smokers within that. But it's been a whole lot of work with our community services, with the case managers, and the actual terminology that we use within our mental health service is called quit or cope. And we found that resonates really well with them. And it was actually created by the consumer that took us to VCAT. So when she actually took us to VCAT, we actually got her on board and said, "Can you help us? We want to get better at this. How should we be framing this?" And that's the wording that we use, and it resonates particularly well. So I think it's all about having that out there, that yes, we are smoke-free, but we will help you to cope, and this is how we will help you to do it. So, we do things like coffee on the couch, where we have a lot of our mental health consumers together, and we'll talk about smoking cessation, we'll talk about weight, the OT will be there, and the social worker, psychology, the medical and pharmacy team. So we're looking at, again, when we're supporting these people to quit or to cope, that we're looking at it really holistically about how we can do that. So I think, starting the conversation as early as possible, making it really, really clear, and being very, very clear, well, what are you going to do to support them? Quite often we just say we're smoke-free. What does that mean for me if I smoke? So I think, it's got to have that support angle.
Yes,
Yeah, I know that you guys were looking at some new signage. Can you tell us where that's at?
Yes, I can. I can probably show you. It just got approved by our oh no, my memory stick isn't in here. That's okay. So basically our new signage is going to be quite different. So we found that the typical non-smoking or no-smoking signage doesn't resonate with a lot of people anymore. It's been around for so long, people don't really see it. Obviously we have to have it because we need to be legislative compliant. but we've learned a lot from our food environment with what we call nudging people. So really introducing the concept of behavioural norms and how we can nudge people to make better choices. So our new signage strategy is going to be using that kind of mentality. So we're going to have things like you can dream, or you can think about Dr. McDreamy here, and then there's this massive cartoon of a very hot doctor, and then it's got, but you can't smoke here. You know, you can make a human pyramid here, but you can't smoke here. You can decipher the doctor's scribble here, but you can't smoke here. So we're looking at, I suppose, using what we've learnt from food environments and also using fun and quirky imagery and taglines to look at really engaging people. So we've done consumer consultation with those. The messages have been approved, and we've got some images that we're looking, and we'll be implementing that probably in the next few weeks. And again, we'll start looking at observational surveys, do it a bit more frequently to see what impact that change on signage has. Also looking at rotating it and the use of movable signage, so using A-frames so that you can move the messaging around different parts rather than kind of typical signage that sits on a wall and doesn't change for 3 years, and then people scratch or burn or whatever they do to it. So it's just taken a little while to get all the consultation for the messages to make sure it's PC enough, and so I'm happy to share that when it's all finalised.
Any question from the video conference group now? Still none. perhaps one more from the audience, then we'd better call it a day. Thank you. Yeah,
so our Aboriginal liaison officer is part of our work, as are other high priority populations. One of the things I think has been most successful is that we've got a really great relationship with VCAT in Melbourne, and Alfred House actually provides education to each of the individual ACOs across Victoria for both consumers and health professionals. So it's again bringing kind of everyone together and having that same message and that same vision. And a lot of the work that we've done within the community has really helped with when patients actually present to Alfred House. So I think, again, it's looking at the opportunities of a health service to work with the community and the community service providers, again, to start this dialogue as early as possible. And I've just been out in the Western District of Victoria, so I visited 7 different ACOs and spoke to probably about 80 community members while I was out there, and I was just so overwhelmed by how much they really, really want to quit smoking, but they just don't know what to do, and very few of them have had any experience with stop smoking medication. They don't know what to expect from it, what it does. So I think, from a consumer perspective, there's a whole lot work we want to do as a leading health service to really improve consumers' perspectives around, these medications and how they can really support them to quit smoking.
Thank you very much, Emma. I've learned a lot today. I'm sure the rest of you have also. This is really groundbreaking work that Emma and her team are doing. We can take it a lot further. I heard Peter Doherty, who's a Victorian former Nobel Prize winner in health, say that if in healthcare you just treat individual patients, we have a duty of care to individual patients, but we also have a duty of care to the determinants of health. And tobacco is obviously one of them. And you're here because you understand that. Several nights ago, my wife and I went and saw the wonderful film on Gurrumal. Jeffrey Gurrumal, the singer with a voice of an angel, who has died, unfortunately, at the age of 46, I think it was. He had a number of health problems, including diabetes and chronic renal failure and liver troubles. But I also noticed in the film that he was a smoker. It is up to us, really, to stop the death of people, any people. But to lose a person of his talent at such a young age is a tragedy. Tragedy for this country, tragedy for the world. That sort of voice doesn't come along too often. Thank you, Emma. Thank you, Sunda. It's been a wonderful morning. Thank you.